Hi medical students, welcome to Anatomy of the Eye. As I'm sure you know, I'm not an ophthalmologist. So I've used these suggested readings to create this presentation for you, and I hope they're helpful. I want to take a minute and go through each of these suggested readings and emphasize their importance. Clinical Anatomy Made Ridiculously Simple is an excellent reference for you to study from for the boards. I've used this before and I'll use it again, and I really emphasize you should purchase this book to study for the anatomy section of your board exams. Gray's Anatomy for Students, the 4th edition, is an excellent textbook. Many of the images in this presentation came directly from this book, and of course, Acland's DVD Atlas of Human Anatomy, which is available through the library site. I've also put a link later in the presentation for you so you can go directly to that video site. I would strongly encourage you to purchase each of these references except for Gray's Anatomy, because we recommend Moore's Clinically Oriented Anatomy, and that's the book that we currently use. Rowan's Color Atlas of Anatomy has also provided photographs for this presentation, and I hope you find them useful. This presentation will not focus on the physiology of eyesight, nor on the neural pathways of eyesight and vision. It's a very basic presentation regarding only the anatomy of the eye itself and of the bony orbit, in which we only briefly mention it. So take your presentation out of presenter mode and double click on the transcript file. You can view the transcript of the entire presentation. I don't think that this works on a Mac. Sorry, Mac users. So let's take a minute and look at the learning objectives. Number 1, name the 6 bones of the orbit. Number 2, what is a radial keratotomy? What is LASIK surgery? Notice that's not Lasix, like the diuretic, it's LASIK. What limitation is placed on the corneal thickness to proceed with this procedure? Number 3, what's the function of the ciliary body of the eye? Number 4, what anatomical part of the eye is referred to the white of the eye? Number 5, what's the function of the cornea and the lens? Number 6, what is fluorescein? And how is it used to remove a foreign body from the eye? You're going to have to Google this one. And then what produces aqueous humor, and where is the aqueous humor located? Next, what is a vitrectomy? Why is it done? What is the canal of Schlemm? Why is it called the scleral venous sinus? Next, what is glaucoma, and what happens if you don't treat glaucoma? Which 2 structures of the eye are considered to be avascular? Next, what is accommodation? How is it related to the ciliary muscles, and what happens if those muscles contract or versus if they relax? What's the result? Number 5, what is a zonial? What does it do and where is it located? Number 6, what is the ciliary body, and what 2 structures form the ciliary body? What is the function of the iris and where is it located? Next, the parasympathetic fibers innervating the iris cause what? Dilatation or constriction. And what about sympathetic fibers? Where do those sympathetic fibers arise from? And then where is the superior cervical ganglion? And why would somebody with lung cancer potentially present with pupillary changes? Next, continuing, name some processes or diseases that can cause a cataract. Next, what is a floater and what causes it? Can vitreous be made in a mature eye? Can we use saline to replace lost vitreous? I have a YouTube video in here that explains what a floater is. Is the choroid vascular or avascular? What about the sclera? Which layer of the meninges covers the optic nerve? What is the optic cup? What is the fovea? Do nerve fibers cross the fovea? Why or why not? What layers form the uvea of the eye? Are they pigmented or not? Which muscle does not originate in the tendinous ring of bones surrounding the optic foramen? And then which muscles of the eye do originate there? What is a lateral tarsorrhaphy? What anatomical structures are sutured? Why is it done? You might want to look this up on YouTube or Google too. Why can't the ocular or the orbital cavity face forward? What is the central line of the orbit in the degrees off of midline? And then be able to identify each anatomical structure in bold font presented in this presentation on a cadaver, a diagram, or photograph. And remember, at the end, I've linked Dr. Acland's video that you'll need to watch too. I've also provided a transcript for him. So to begin with, this is a color image taken from Rowan's Atlas, which shows the 6 bony landmarks which make up the bony orbit of the eye itself. In this photo, the zygoma is on the right side of the screen. It's in the yellow, and it extends laterally. And then what you're looking at here is the left side of an intact skull, which has been painted for you to see the landmarks. The 6 bones which make up the bony landmarks include the maxilla, the zygoma, the frontal bone, the ethmoid bone, the sphenoid bone, and the palatine bones. This will all be, this is all I'm going to say about these bony landmarks. I won't really cover the facial bones or the facial muscles in this presentation. So here's a mid-sagittal section of the eyeball. You should be able to sketch this out briefly so that you can clearly understand the different layers of the eye. You've seen multiple pictures of this throughout your medical career, and you'll see it more times. Starting from the right and moving to the left, we see first the cornea. And the cornea gains attention today because we're able to perform radial keratotomy or LASIK surgery on it. Whether a person can have LASIK surgery or even radial keratotomy, which is the older and less used visual corrective surgery, depends on how thick the cornea is. If your cornea is too thin, they won't be able to perform the surgical procedures. And I show some images later of some corneas that have been subjected to LASIK or radial keratotomy. Continuing, we find the anterior chamber and the posterior chamber and the ciliary body, which we'll learn a little bit about, and the lens, which we'll see a nice photo of later. The muscles which hold the lens in place and of the ciliary body, which controls accommodation, are illustrated, and of course the vitreous chamber. And more posteriorly, we see the fovea centralis, and of course the optic nerve. The retina, the choroid, and the sclera itself are all mentioned in this presentation. The sclera, of course, is referred to as the white of the eye. The cornea is responsible for providing coarse focus. It's only about 1 millimeter thick and consists of epithelium, and damage to the corneal endothelium can result in corneal clouding. The lens, of course, provides for fine variable focus. So please understand this distinction. The cornea provides for coarse focus, while the lens provides variable focus. Here we see some images made as a result of radial keratotomy and or LASIK. Bowman's membrane, which we will refer to again, lies just below the epithelial layer. Here's a diagram taken from Clinical Anatomy Made Ridiculously Simple. This shows the layers of the cornea. It demonstrates the corneal epithelium directly underneath Bowman's membrane, and the stroma, as well as Decimet's membrane, and of course the endothelium. It is the thickness of this cornea, which in this photo looks very thick, but remember it's only about 1 millimeter thick, and it's this thickness which determines whether you can have LASIK surgery. As a family physician, one of the common problems which you might run into is a patient who presents with a corneal foreign body, corneal laceration, or abrasion, usually caused from a piece of metal that gets stuck to the patient's cornea. If your community RDME could potentially guide you into how to perform a slit lamp examination of the eye and to carefully remove that small piece of metal from someone's cornea and numb up the cornea, it'd be very helpful to you in your clinical training. A hint, use fluorescein. You'll want to look that up, see what the medication is, fluorescein, and how it's used. The chambers of the eye, which we've already seen, the anterior, the posterior, and of course the vitreous chambers, contain different substances and function differently. The anterior chamber sits in front of the iris, i.e. anterior to the iris, and it contains aqueous humor, which is produced by the ciliary body. The posterior chamber sits between the iris and the lens, and it also contains aqueous humor. And of course the vitreous chamber sits behind the lens, the large round chamber which contains fluid, which is often removed by a procedure called a vitrectomy. Again, here we see the anterior chamber and the posterior chamber. These are well demarcated in this photo, and the vitreous chamber is well seen too. The canal of Schlemm, which is how I learned it, is now called the scleral venous sinus, is very important because if this canal of Schlemm becomes obstructed, it can lead to an elevated intraocular pressure called glaucoma, and that can lead to blindness. The canal of Schlemm communicates directly with the venous system, and if you look closely at these pictures, you'll see that the canal of Schlemm lies in the angle between the cornea and the iris. And it's also noted that the cornea and the lens are considered avascular. Aqueous humor exits the eye via the circular canal of Schlemm, and if this exit becomes blocked by disease or debris or some other process like infection, it can cause glaucoma, which is quite common. There's closed angle glaucoma and open angle glaucoma, but they are beyond the scope of this presentation. So accommodation is the result of a process in which the ciliary muscles contract and release tension on the lens, causing thickening of the lens and thus allowing closer focusing. There are very thin ligaments called zonules which attach to the lens via the ciliary body. These change the shape of the lens, and it is this change in the shape of the lens which causes accommodation. Remember, accommodation is the process by which the ciliary muscles contract, releasing tension on the lens. Again, it's where the muscles contract. Please remember this because it's a little bit backwards to what you may think. Here's a nice photo from Rowan's Atlas of Anatomy showing the zonules, the ciliary bodies, and the ciliary muscles. Of course, the lens is directly in the center. Over on the right, we see the exact same photo of what they actually look like in situ on a slit lamp examination performed by an ophthalmologist. This is a nice close-up view of the relationship between the ciliary body, the zonular fibers, and the canal of Schlemm. Moving from right to left, we see the cornea, the anterior chamber, the iris, of course, and the scleral venous sinus, and you can see how small this is. Remember, the canal of Schlemm goes by the name of the scleral venous sinus. The ciliary body is made up of the ciliary muscle and the ciliary processes which connect to the lens by the zonular fibers. I've also put a link here to talk about floaters, how they're caused, and how they're treated. So here's a picture taken from Clinical Anatomy Made Ridiculously Simple, where we see a little man standing in the center looking out of the lens. The zonules connecting to the ciliary body, and these result in accommodation when the muscle fibers contract, causing a change in the shape of the lens itself. If you want to see this in more detail, click on the link to the accommodation video. Now again, look at this picture. Here's a ciliary body, the zonular fibers, and the lens. It's a beautifully dissected photograph. And if you want to see how the lens is removed during cataract extraction, there's a couple of video links I've put here for you. The iris, of course, controls the amount of light which enters the lens. There are muscles of the iris called the constrictor muscles of the iris, innervated by cranial nerve 3, the oculomotor nerves. These are parasympathetic fibers. The muscles which dilate the iris are innervated by the superior cervical ganglion in the neck, and these are sympathetic fibers. This is a very simple slide, but it contains important information. The constrictor muscles, which as you can see are located around the pupil, and the dilator muscles, which move radially. Remember, the dilator muscles are innervated by the sympathetic fibers from the superior cervical ganglion in the neck. The constrictor muscles are innervated by the parasympathetic fibers, and they're innervated by the oculomotor nerve, cranial nerve number 3. Now here's a nice close-up picture of the iris, and with some imagination you can actually see the circular constrictor fibers. If you want to see how astigmatism is addressed, which is an abnormality in the shape of the cornea, you can click on this link here. Of course, we all know about cataracts. We've heard about cataracts. There are many diseases which can cause them, including diabetes, genetic diseases, and even electrocution, where they can occur later. Besides some biological genetic diseases which can cause cataracts, we often see that cataracts are seen in patients with diabetes. Cataracts in the anterior lens, or at the periphery, of course, will cause less visual loss than those directly in the center of the lens. It is this clouding of the lens, the opacity, which is referred to as a cataract. Cataract surgery today is routine and is performed by removing the lens. Years ago, the lens was sutured in place. Today, the lens is replaced by a sutureless technique. Here's a picture of a human lens, not a man-made lens, which is often used to replace the human lens. And on the right, we can see dissection of this. The vitreous humor, which you saw, which makes up most of the volume of the globe and is a thick gel, it can be replaced by saline during surgery, and it's not produced in a mature eye. This drying of the vitreous humor often results in what we call floaters, and hopefully you watched that video link earlier. So as we get older, we can see small spots in our vision, and these floaters or black spots are the result of drying or loss of the vitreous humor. Again, the vitreous chamber is where the humor is located, and it's drying of this and loss of this which causes floaters. When we grow older, the mature eye does not produce any more vitreous fluid. Here's an image of chorioretinitis. Layers of the eye, the retina, the choroid, which is highly vascular, and the sclera, which is avascular, i.e. the white of the eye. I always think of the saying from the American Revolutionary War when America was engaged by the British and were told not to shoot until they saw the white of their eyes. So another comical image from Clinical Anatomy Made Ridiculously Simple showing these layers, and I think one of the best ways to learn the anatomy of the eye is to be able to draw it. Showing in this picture a contact lens sitting on top of the cornea, the anterior chamber, the lens, and the small man looking outward, the vitreous chamber, and you can see at the very back of the eye how the optic nerve is covered by dura mater. We see the superior rectus muscle, the inferior rectus muscle, and more anteriorly we see the skin and layers of the eyelid proper, which we'll talk about in just a minute. Two images also of retinal detachment are shown. We don't necessarily go into how this is treated, but here's an ophthalmic view of the retina detached. The optic cup is where the blood vessels and the nerve fibers leave the eye and enter the optic nerve. The fovea lies a little bit lateral to the optic disc. Your best vision is concentrated here at the fovea. Nerve fibers from all regions of the retina extend towards the optic disc but do not cross the fovea. And this makes sense. Your best vision is the fovea, and if it was covered by nerve fibers, those nerve fibers would obstruct the vision. So the fovea has really no nerve fibers that are crossing this area. Here's another picture from Clinical Anatomy Made Ridiculously Simple showing us from the nasal side moving temporally, which shows us how the fovea is more lateral, i.e. more towards the temporal side. And we can see the optic disc, the optic cup, which is directly in the center. And we can see the disc margin, but none of the nerve fibers, as you can see, cross the fovea laterally. None of the nerve fibers cross the fovea. Here's a picture taken with a digital ophthalmoscope. You can see the optic disc, the fovea centralis, and the multiple vessels. The fovea is the thinnest area of the retina. Of course, as we've already said, it's the area of highest visual sensitivity. You might remember from college or high school learning about rods and cones. Rods are insensitive to color. Cones are responsible for color vision. Of course, we all remember this by C for cones and C for color vision. And I was always taught that rods were responsible for black and white vision, but I think it's probably best today that we think about this as just that rods are simply insensitive to color. So again, the fovea is the thinnest area. It's not covered or crossed by any nerve fibers. It has very few rods and more cones, which allows us to see in color. The uvea is a structure which is a combination of several other anatomical structures. The uvea is made up of the choroid, the ciliary body, and the iris. All of the above form the pigmented layer. So if you remove the white of the eye, i.e. if you remove the sclera, the entire underlying eye is pigmented. If the choroid becomes inflamed, this can result in chorioretinitis. We saw that in an image earlier, an inflammation of the retina and the choroid body. So the uvea is a mixture of the choroid, ciliary body, and the iris, which I've noted here for you. Please refer to this photo of the eye and see all of these layers. So again, looking at these layers, and the sclera, the choroid, and the ciliary body all coming together to form the uvea. So the uvea is a mixture of choroid, ciliary body, and the iris. Please refer to a photo of the eye to see all of these layers. And here we can see all of these layers. The choroid, the ciliary body, and the iris all coming together to form the uvea. Now let's take a minute and talk about the muscles of the eye. Clinically, this is probably the most important portion of the anatomy for you to learn. You'll need to learn which muscles are innervated by which nerves and how, when someone has a nerve deficit or nerve damage, we call that a nerve palsy, that they'll be able to move their eyes or not. So the muscles of the eye, of course, include the superior and inferior obliques, the superior rectus, the inferior rectus, the medial and lateral recti. Take a moment to look at the photo on the right from Gray's Anatomy and how it shows the medial and lateral recti muscles and the inferior rectus. And just beneath it, we see the inferior oblique. This relationship will become a little bit more important later when we take a view of these oblique muscles. Looking at a cadaver specimen laterally, the lateral rectus has been divided and reflected. And here we see the muscles of the eye, which you can more clearly see the superior and inferior rectus muscles and the optic nerve. Remember, the optic nerve is covered by dura mater. So, none of the muscles of the eye attach to the temporal wall of the orbit. Say it again. None of the muscles attach to the temporal wall of the orbit. Each extrinsic muscle of the eye attaches not only to the eye globe itself, but it also attaches to the nasal aspect of the orbit. One more time. None of the eye muscles attach to the temporal wall of the orbit, and each of the extrinsic muscles attach to the nasal aspect of the orbit. So here's a view, and if you look closely at this cadaver specimen, you can see all of the eye muscles sort of spinning around back towards the optic nerve, attaching at the nasal aspect. None of the muscles attach at the temporal aspect. So again, we know all of the muscles, including the levator palpebrae muscle, originates in the tendinous ring. And we're going to look at this tendinous ring here in just a second. The inferior oblique is the exception to this. It attaches to the maxillary bone. So, the levator palpebrae muscle originates in the tendinous ring of bone surrounding the optic foramen. All the muscles there except the inferior oblique muscle originate at that point. This is a picture mostly thrown in just to show you the levator palpebrae muscles, the tarsus and the lacrimal glands and ducts. The tarsal plate becomes important in performing a lateral tarsorrhaphy, and we'll talk about that in just a second. Back to the tendinous ring of the muscle of the eye. Here on the left, we can see the tendinous ring, which is very well demonstrated in the photo. We can see the optic nerve, the ophthalmic artery, and then the third cranial nerve, along with V1, and the abducens nerve, cranial nerve 6. The sixth cranial nerve coming from the medial nasal aspect of the orbit. On the right, we can see where the muscles originate from. The superior rectus, the levator palpebrae superioris, the superior oblique, and the medial rectus, the inferior rectus, and the lateral rectus. Please pay careful attention to where each of these originate and their relationships. You'll need to refer to this picture multiple times during the presentation. There's been a mnemonic generated to help you remember and understand the innervation of the eye muscles. Think back to your days in organic chemistry or chemistry 101. LR6, SO4, R3. This simply means that the lateral rectus is innervated by the 6th cranial nerve, the abducens nerve, and it's responsible for abducting the globe of the eye. The superior oblique is innervated by the 4th cranial nerve, and all the remaining muscles are innervated by cranial nerve 3, the oculomotor nerve. The muscle which closes the eye is innervated by cranial nerve 7, the facial nerve. The muscle which opens the eye, the levator palpebrae superioris, is innervated by cranial nerve 3, the oculomotor nerve. Clinical anatomy made ridiculously simple has given us an image to help us remember this. We'll see it here in just a second. So one more time, LR6, the lateral rectus is innervated by the 6th abducent cranial nerve. SO4, superior oblique is innervated by the 4th cranial nerve, and all the remainders, R3, are innervated by the 3rd cranial nerve. So here again is a photo of these muscles showing the most impressive trochlear nerve, number 4, cranial nerve 4. The trochlea is a word that means pulley, and the 6th cranial nerve, the abducens, innervates the superior oblique muscle, which forms a pulley up on the medial aspect. This picture shows us the 4th cranial nerve, the trochlear nerve, the superior rectus muscle, and the levator palpebrae superioris muscle, which helps to keep the eye open, and of course the medial rectus. So remember, LR6, SO4, R3. Here's a superior view of what we just saw. On the left we see an image of the trochlea controlling the superior oblique muscle, and we see the globe of the eye and the medial rectus and lateral rectus muscles. And on the right, we see an image of the skull from a cadaver where the optic nerve has been divided at the optic chiasm, and then we can see the nerves running into the muscles of the eye from above. So here's our picture from Clinical Anatomy Made Ridiculously Simple to help us remember this. The orbicularis muscle is innervated by the 7th cranial nerve. So if a patient has surgery, let's say on a parotid gland tumor, and the parotid gland and the facial nerve have a very intimate relationship, and a branch of the facial nerve is damaged, this can result in the patient having an inability to completely close their eye. So he's trying to show us in this silly picture that the 7th nerve is like a hook pulling down on the muscle of the orbicularis muscle. Then, of course, we see cranial nerve number 3, which holds the eye open and controls the levator superioris palpebrae muscle. The patient who has a parotid gland surgery and who could have damage of the facial muscle could result in an eye that can't close, and this is treated by a procedure called a lateral torsorrhaphy, where the eye is closed by sutures or at least partially closed by sutures to prevent the eye from drying out. So this is a great picture. It's simple, but it helps you to remember the 7th cranial nerve closes the eye, the 3rd nerve holds it open. Obviously, here we have a cadaver specimen of the tarsus, which is contained within the eyelid. It is sutures that are placed within this tarsus, which allows a surgeon to partially close the eye if there's been damage to the 7th nerve, to the facial nerve, causing an inability to completely close the eye. Disease, tumor, or inadvertent surgical injury to a branch of the facial nerve can cause this. So here we are, summary of the eye muscles. I'm sorry, but it's a very busy slide. It's reproduced directly from Clinical Anatomy Made Ridiculously Simple. There's no other way to tell you quite bluntly that you need to look at this chart and in combination with the next slide, practice testing those eye muscles on your clinical and your neurological exams. So these two slides, this slide and the previous slide, without spending a lot of time, need to be printed and basically memorized so you can learn how the eye moves and how a deficit of any of the cranial nerves that innervate the eye, LR6, SO4, R3, will produce varying deficits and or movement deficits of the eye itself. If you're unclear, return to my webcast on the cranial nerve review and palsies of the cranial nerves to review some of these. And I suggest that you also Google Optho book. This book is great, and the accompanied website is terrific to help you understand some of these ocular nerve palsies. So the copyright notice is here to remind me that coming up is Dr. Acland's video of anatomy of the eye. He does a beautiful job, and I've included a transcript of that also. On the next slide, if you click on the link provided, and if you're logged into ATSU via their intranet, i.e. if you're on campus, you should be able to see and download this directly on your computer. But if you're at home, you'll have to log into the library to get access to it. Hope you enjoyed the presentation. Pay attention to the transcript, the learning objectives, and to Dr. Acland's review of the anatomy of the eye.
In this section, we'll look at the eye and its surroundings. We've already seen the nerves of the orbital region in part 3 of this tape. In this section, we'll first look at the bony features of the orbital cavity, then we'll look at the eye itself, then at the eye muscles, and lastly, the eyelids and lacrimal apparatus. Let's start with the bones. This is the bony orbit, or orbital cavity. It's described as having a roof, a floor, a medial wall, and a lateral wall. The rim of the orbit is called the orbital margin. It's thick and clearly defined above, laterally, and below. Here, medially, the orbital margin is less distinct. The medial wall of the orbit blends with the contours of the nose and the central part of the forehead. The orbital margin curves distinctly backwards, both above and below. Because of this, the orbital margin is much further back laterally than it is medially. This reflects an important fact about the orbital cavity. It doesn't face directly forwards. We can see this best in a skull in which the roof of the orbit has been removed. This lets us look down into the orbit from above. The medial wall of the orbit faces directly forward, but the lateral wall is angled outward by about 45 degrees, so that the center line of the orbit is a little over 20 degrees off the midline. As we saw in tape 4, several bones are involved in forming the orbit. Starting medially, this is part of the ethmoid bone, this is the underside of the frontal bone, this is the zygomatic bone, this is part of the maxilla, so is this, and this is the lacrimal bone. Back here are the greater and lesser wings of the sphenoid bone. Here at the narrow apex of the orbit are the optic canal and the superior orbital fissure. The optic canal transmits the optic nerve and ophthalmic artery. The superior orbital fissure transmits the other nerves that enter the orbit and the superior orbital vein. In the living body, the inferior orbital fissure, which forms an apparent gap between the floor and the lateral wall, is bridged over with fibrous tissue. This groove, the lacrimal groove, leads downwards into the opening for the nasolacrimal duct, which takes tears to the nasal cavity. The rim of the lacrimal groove is formed by the posterior lacrimal crest behind and the anterior lacrimal crest in front. The medial palpebral ligament is attached here, the lateral one here. The palpebral ligaments hold many of the anterior structures of the orbit in place. Now we'll move on to look at the main externally visible parts of the eye itself. In life, we see only a small part of the eye. Even at the limit of eye movement, we see less than half of its circumference. Here's the eye, seen from above. It occupies only the anterior part of the orbit. The space behind it is largely occupied by fat that's been removed in this dissection. The tough outer coat of the eye is the sclera. The sclera extends from here behind, where the optic nerve passes through it, all the way around to here in front, where it becomes continuous with the transparent cornea. The cornea is the transparent window that allows light to enter the eye. The cornea is more sharply curved than the sclera. It bulges forwards. Behind the cornea, the colored iris forms an incomplete partition within the eye. At the center of the iris is a clear opening, the pupil. The size of the pupil is constantly changing to limit the amount of light that enters the eye. The iris is chiefly formed of muscle fibers. Fibers arranged radially cause the pupil to dilate. Fibers arranged circumferentially, both here and out here, make it constrict. The lens of the eye is just behind the iris and the pupil. Here, light from a slit lamp is coming in from the left side. Down here, where it's very bright, the light is hitting the iris. Here, where it's fainter, it's hitting the anterior surface of the lens. The internal structures of the eye are so delicate and so readily displaced that they can't be well shown by dissection. They're better understood by referring to microscopic images and diagrams, to which I hope you'll have access. Now we'll move on to look at the extraocular muscles. There are 7 of them. One, as we'll see, raises the upper eyelid. The other 6, the 4 rectus muscles and the 2 oblique muscles, move the eye. The best way to look at these muscles is from above. Here, we're looking down into the orbit in a dissection in which the orbital roof has been removed. We'll start by looking at the rectus muscles. To see them, we'll take these 2 muscles, the levator and the superior oblique, out of the picture. We'll also remove some of the fat that largely fills the posterior part of the orbit. Here are 3 of the rectus muscles: superior, lateral, and medial. To see the inferior rectus, we'll remove the superior rectus, the optic nerve, and the rest of the orbital fat. Here's the inferior rectus muscle. Between the origins of the rectus muscles, the optic nerve emerges. The rectus muscles arise together from inside a ring of fibrous tissue, the annulus tendineus, of which this is the upper part. The annulus is attached to the periosteum of the apex of the orbit. Its ring of attachment, represented in blue here, encircles the optic canal and this part of the superior orbital fissure. The optic nerve, the ophthalmic artery, and several of the nerves to the orbit pass through the annulus. The rectus muscles thin out into 4 flat tendons as they pass forwards around the eye. They insert into the sclera quite far forward. To see where they insert, we'll go round to a view from in front. Here's the insertion of the superior rectus. Here's the lateral. Here's the inferior. Here's the medial. The main actions of the rectus muscles are obvious. The superior and inferior rectus muscles turn the eye upwards and downwards. The lateral and medial ones turn it outwards and inwards. The inferior and superior rectus muscles have another action too. They don't only pull the top or bottom of the eye straight backwards, they also tend to rotate it a little about its long axis. The superior rectus, acting alone, would rotate the top of the eye inward as we look up. The inferior rectus would rotate it outward as we look down. In fact, the rectus muscles don't act alone. They act in conjunction with the 2 oblique muscles, the inferior oblique and the superior oblique. We'll add those to our picture, starting with the superior one. Here's the superior oblique muscle. Like the rectus muscles, it arises from the annulus. The superior oblique narrows into a tendon which passes around this sling of fibrous tissue, the trochlea. The trochlea is attached to bone here, behind the orbital margin. The trochlea acts as a pulley. The superior oblique tendon fans out, passing deep to the superior rectus, to insert into the sclera on top of the eyeball. We'll go round to our view of the eye from in front and add the oblique muscles to that picture. Here's the trochlea. Here's the superior oblique tendon. The superior oblique muscle, acting alone, would rotate the top of the eye medially. The inferior oblique muscle is down here. It's the only extraocular muscle that doesn't arise from the annulus. It arises here, behind the inferior orbital margin. It inserts into the sclera quite far back. To see that, we'll go round to our view from above and behind. Here's the inferior oblique, inserting into the sclera between the lateral rectus and inferior rectus muscles. The inferior oblique, acting alone, would rotate the top of the eye laterally. The oblique muscles act in conjunction with the rectus muscles, the inferior oblique with the superior rectus, and vice versa. This prevents our eyes from rotating about their long axes as we look up and down. The last of the 7 extraocular muscles to look at is the levator of the upper eyelid, levator palpebri superioris. The levator lies just above the superior rectus muscle. Here it is. Arising from the annulus fibrosus back here, the levator fans out to become a broad tendon which inserts, as we'll see later, mainly into the tarsus of the upper lid. Incorporated in the underside of the levator is a strip of smooth muscle, the superior tarsal muscle, that's innervated by sympathetic fibers. Changes in the tone of this smooth muscle cause our upper lids to droop when we're tired and open wide when we're excited. As we saw in the section on the cranial nerves, the extraocular muscles get their nerve supply from the 3rd, 4th, and 6th cranial nerves. The superior oblique is supplied by the 4th nerve, the trochlear. The lateral rectus is supplied by the 6th nerve, the abducent. The other 5 muscles are supplied by the 3rd nerve, the oculomotor. In the images that we've seen so far, the muscles have been dissected bare to show them clearly. But in reality, each of the muscles, as it passes forwards, becomes surrounded by a sliding sheath of fibrous tissue. The fibrous sheaths of adjoining muscles blend together to form a hood above and below the eye. This hood is firmly attached to periosteum at 2 points, here laterally and here medially. These fibers of attachment form the posterior parts of the lateral and medial palpebral ligaments. Indirectly, they hold the eye in position in the orbit. The tendon sheaths of the muscles are also continuous with this sheath of fibrous tissue, the capsule of the globe, that surrounds the posterior 2/3 of the eyeball. Now that we've looked at the extraocular muscles, we'll move on to look at the eyelids and the lacrimal apparatus. The eyelids form a movable protective covering for the eye. The upper and lower lids are much alike. We'll look mainly at the upper one. In looking at the structures that form the eyelids, we'll switch between a dissection from in front to one in which the structures have been divided in steps, a layer at a time, giving us this lateral view. The eyelids are covered on the outside with skin that's extremely thin and mobile. They're covered on the inside by a thin sensitive membrane, the conjunctiva. This is the conjunctiva. Conjunctiva also covers the front of the sclera. The conjunctiva that covers the sclera, the bulbar part, and the conjunctiva that lines the lid, the palpebral part, are continuous at this fold, the conjunctival fornix. The conjunctiva is continuous with the skin at the margin of the eyelid. Directly beneath the skin of the eyelids, which we'll remove, is the orbicularis oculi muscle. As we saw in part 1 of this tape, the orbicularis extends beyond the margins of the orbit onto the forehead and the cheek. It's such a thin muscle, parts of it are almost colorless. Medially, many of its fibers arise from this structure, the medial palpebral ligament, which is attached to bone here at the anterior lacrimal crest. The more outlying fibers of orbicularis arise from bone here around the lacrimal groove. Laterally, the innermost fibers of orbicularis insert into bone here. The more outlying fibers have no bony attachment. This is part of the orbicularis. It's been divided along this line. Directly beneath it is this layer of fatty fibrous tissue, the orbital septum, that extends into the lid from the periosteum at the orbital margin. The orbital septum separates the contents of the orbit from the facial soft tissues. Here beneath the orbicularis is the structure that gives the eyelid its shape, the tarsus. It extends from here to the lid margin. To see the tarsus from in front, we'll remove the orbicularis muscle and then the orbital septum. We have also removed much of the orbital fat. The tarsus is here. If we put something underneath it, we can see its upper border. The tarsus is tethered at each end to the palpebral ligaments. The tarsus is quite flexible. It stiffens the eyelid and gives it a curvature that varies so that the shape of the eyelid conforms to the changing curvature of the underlying eye. Within the thickness of the tarsus are numerous tarsal glands. This is one of them. The tarsal glands open here, right along the margin of the lid. The tarsal glands produce an oily secretion which prevents the spillage of tears. This structure, coming down from behind, is the levator muscle. This is its tendon. The levator tendon inserts mainly into the tarsus. Its most lateral and medial fibers are attached to the palpebral ligaments. Here's the orbital margin. Here, just below and behind it, is the lacrimal gland, which secretes tears. It lies in this hollow in the roof of the orbit, the lacrimal fossa. The many small ducts of the lacrimal gland open into the conjunctival fornix up here. Tears leave the space in front of the eye through two small openings called puncta. Here's the lower punctum. To see the upper one, we'll roll the upper lid outwards. Here's the upper punctum. To see where the puncta lead, we'll look at a dissection in which the orbicularis has been removed and blue material has been injected into the puncta. Here's the upper punctum. Here's the lower one. Leading from them are the canaliculi. Here's the upper canaliculus. Here's the lower one. The two canaliculi converge behind the medial palpebral ligament, which we'll remove. The canaliculi join together and enter this reservoir, the lacrimal sac. The lacrimal sac is surrounded by the fibers of origin of the orbicularis muscle. When we blink, the pressure from these muscle fibers squeezes tears from the lacrimal sac down into the nasolacrimal duct. Now that we've looked at the eyelids and lacrimal apparatus, let's review what we've seen of the eye and its surroundings. Here's the orbital margin, the optic canal, the superior orbital fissure, the inferior orbital fissure, the lacrimal groove, the posterior lacrimal crest, and the anterior lacrimal crest. Here's the sclera, the cornea, the iris, and the pupil. Here are the rectus muscles, superior, lateral, medial, and inferior, and the oblique muscles, superior, and inferior. Here's the trochlea. Here's the annulus tendineus. Here's the conjunctiva, palpebral and bulbar. Here's the orbicularis oculi muscle, the orbital septum, the tarsus, and the tarsal glands. Here's the lacrimal gland, the upper and lower puncta, the canaliculi, the lacrimal sac, and the nasolacrimal duct. That brings us to the end of this section on the eye and its surroundings. In the next section, we'll look at the ear.